Good afternoon, everybody, and welcome to this first COVID-19 seminar series from the Melbourne Children's Campus. My name's Andrew Steer. I'm the Director of Infection and Immunity at the Murdoch Children's Research Institute and co-chair of the research program here with Sharon Goldfeld. And we're just delighted to have you here today. I'm just going to share my screen. So this is the first in a series. We'd like to begin by acknowledging all First Nations people, specifically the traditional custodians on the land of which our campus is located, the Wurundjeri people of the Kulin Nation, and acknowledge the traditional custodians of where you may be located today. And we pay our respects to their elders past, present and emerging. Just a little bit of background about the program of research that's taking place on this campus. It's in three priority areas: prevention and treatment, infection and transmission, mental health and wellbeing, with impact that comes from those priority areas, and then a series of program of work from each of those specific areas with impact. And we do have, from that large program, and it is a very large program, a number of areas for strategic direction, including vaccine preparedness, long-term physical and mental health impact on children and families, prevention of COVID-19 through BCG vaccine, the BRACE trial, global health, and infection and transmission in Australia. But today we're focusing on getting back to school. Sharon and I wanted to acknowledge the steering committee, which is directing all of this work. You can see there are a number of fantastic members on that group, and we've already had significant activities, output and contributions with over 80 projects on the campus, which is pretty remarkable, with 20 rapid reviews and now up to 60 academic papers that have come from this work. We do just want to highlight that our second seminar of the series will be coming up on Friday, the 6th of November on vaccine preparedness, and we'll be communicating with you about that seminar. But today is about back to school, and just a few housekeeping issues. We're having some presentations first, which I'll introduce in a moment. There'll be no questions during the presentations, but there'll be opportunity in the discussion, which is the second half of today. So please send your questions in via the Q&A box, which is at the bottom of your screen. We're going to aim to keep this webinar today to 1 hour, but it will be recorded and available at a later date. So it gives me great pleasure to introduce our three presenters today. Professor Sharon Goldfeld, who is Director of the Centre for Community Child Health at the Children's Hospital. She's also Theme Director of the Population Health Theme and Co-Group Leader of Policy and Equity at MCRI, and she's a Professor in the Department of Paediatrics at the University of Melbourne. Also gives me great pleasure to introduce Fiona Russell, who is Director of the Child and Adolescent Health PhD Program at the Department of Paediatrics. She's a Group Leader in Pacific Health, Asia Pacific Health at the Murdoch Children's Research Institute. And finally, Kathleen Ryan, who's Research Fellow within Asia Pacific Health at MCRI, who's currently working as an epidemiologist for DHHS during the COVID response. So let's get into it. And our first speaker will be Sharon. So Sharon, over to you. Thanks so much.
Thanks very much. And I'm going to also share my screen and hope for the best. So good afternoon, everybody. I'm delighted to join you here today. It's been a very interesting journey for us doing this work on opening schools. And I'm going to talk a little bit about what we know about some of the impacts of school closure. But I particularly want to just acknowledge, for those of you who might have seen some of the media, the press conference at the time, you might not have known there was a set of slides that got set up. These are available on the DHHS website. And on it, they had a bit of information which we're going to share with you today, but this very important quote, which is about really the summary of all our work, which is this idea of prioritising schools and early childhood education and care for reopening and staying open. And I really want to emphasise that today one of our concerns, we're certainly doing this work as scientists, but we're also really concerned about the impacts of school closures on children. And our ability to bring that science together with understanding the impacts of children has really been an important part of this work. We have had a little bit of fun with it all. So 3AW suggested that we should all become Victorians of the Year, and sure, if anyone wants to nominate us, that'd be great. Actually, I don't think there is a Victorian of the Year, but still, it was a kind of fun thing. We also published in The Conversation for those of you who are interested in looking at that, and we made, I think, the front page of the Herald Sun. I think Fiona's got some of this later as well. So there were some kind of great things that emerged out of that, in a real sense that we were making a difference for the 1 million students that weren't going to school in this state. When we're thinking about the impacts of children on children and adolescents, and I think it's important to note it, especially for, sorry, I've just had another screen come up, especially noting it, these different waves. So we've got this original wave, which is the kind of acute impact, but I really want to talk about this second wave, which is kind of where we are now in terms of the months past COVID, where we're really looking at this impact of the fact that kids can't get into services, the impact on school closures, etc. And I think that's been the real challenge for us, is thinking about what do those impacts mean? And they're these immediate ones. So just to give you a sense of the world, so by April 2020, school closures impacted about 86% of the global student population. So that's 1.4 billion children. And in around Australia, that was around 4 million students. And I want to share with you just as kind of this cool thing that's on the UNESCO website, just looking at what those closures look like. So this was back in April, and the dark colour is the number of countries that actually had full closure of their schools. So you get a sense of that enormous global impact. And as you can see, 1.5 billion learners, this is across early childhood right through high school. This is what it looks like at the moment, today, or yesterday actually, or the day before yesterday. And you can still see there are a number of countries that are closed completely, a number of countries with partial closure, and still 500 million children still impacted. So enormous. Now, this isn't the first time we've thought about this. So this is a quote about more evidence needed about the efficacy of school closures. And I thought it was kind of cool because actually this was a quote from 2008. So we actually are no better off in really understanding the impact of school closures, but a reminder about how important it is to actually measure that. This is also from the UNESCO site, just some of these adverse consequences of school closures that actually don't even include the impact on children's health and development. Things like the confusion and stress for teachers, sorry about the typo, parents being unprepared for the distance learning, teachers being unprepared for their distance learning, the high economic costs because parents can't work, the unintended strain on healthcare systems because healthcare workers can't work. So there are all these adverse consequences of school closure. It's not even about the closure of the school itself. But there are impacts on children, and this is emerging as things for us to think about. So almost all the literature I'm providing you is the sense of this is what's coming our way. These are the things we're starting to see. Children being physically less active, longer screen time, lost access to public health interventions, particularly the nutrition interventions, lunches, etc. The mental health effects, I think we're all really worried about, and any of us that are parents are seeing it. Fears about the virus itself, lack of motivation, lack of seeing their friends, and for adolescents, lack of personal space in the home. And we know this is particularly bad for vulnerable populations. These kids, particularly the younger ones, are missing out on these critical early years of learning. And we're really worried. We know that the burden is going to be disproportionate for children going forward. And of those, is going to be disproportionately for those children who are living in adversity. So the impact of long-term school closures is something we don't actually know. And I think the burden on us as researchers is to go forward and try and measure that and understand that into the future. And interestingly, Peter Singer was in the Age this morning as an ethicist talking about we don't really understand these long-term impacts. And what will that mean when we're looking at balancing what the public health mitigation strategies did versus the long-term impacts of them. But just a little, this is hot off the press. Thank you to Anthea Rose. This is from the second of our RCH National Child Health polls this year. And this is a particular question that got asked between September the 15th and September the 28th, and allowed us to look at the differences between Victoria, New South Wales and all other states. And one of this question that was asked this time, which is the impact of remote learning on your child's emotional, behavioural and social well-being. And you can see the difference there between Victoria, New South Wales and all other states. So we're actually now getting some real-time live data that are telling us that parents are feeling the negative impact of remote learning on their kids' learning. Just some little potential strategies that I just wanted to leave you with before I hand over to Fiona to really go through the report. One is a project that we're doing called Mental Health in Primary Schools. It's been funded through the Victorian Government and the Potter Foundation, which is looking at improving the mental health capacities of schools, which I think will be very, very important and a really important part of some of these interventions going forward. The second is that the Melbourne Graduate School of Education, I've included the URL there for those of you who are interested, have spun up a series of recommendations of what you can do based on the available literature. And I think these might be very helpful for schools and sharing with schools about the sorts of things they might do. I do have to say though, we've been working and Jess Clark has led a rapid review of looking at interventions that we can do, either mental health interventions or academic interventions following a crisis, particularly looking at external disasters. What's concerning is when we had a look at academic interventions that are actually available that have had good, good research, there was a sum total of 0. We looked at mental health interventions following a crisis, and there were 9 as a total across the whole world, almost all of them in the United States. But the message is think about particularly the universal and the targeted things you can do in schools, and all of these are available and coming out. So that's my last slide, and I might just hand back over now to Fiona.
Thank you, Sharon. And so firstly, I'd just like to thank very much the team that was involved in this work with the Department of Health and Human Services and also the Department of Education, and particularly Dr. Kathleen Ryan and Dr. Catherine Snow, who are the epidemiologists who have worked jointly with the department as well as MCRI and also the School of Population Health at the University of Melbourne, and all the medical students and Bell Overmars who contributed to this work. So our first thing that we were to do was to summarise what is known about the role of schools in transmission, what other countries are doing in terms of mitigation measures, analyse the data, which Kat will talk and show later, and then provide recommendations to the department on opening up early childhood and schools safely. And so first, I just want to have a slide and talk just about transmission of SARS-CoV-2 in general. So it's becoming increasingly more obvious that clusters are the prominent characteristic of the virus and how it is spread. And it's thought that about 10 to 20% of cases in the community, this is everyone, I'm not talking about schools here, this is everyone, is responsible for about 80% of all infections that occur. So what that means is that many infected people do not or have minimal potential to actually contribute to onward transmission. And this picture up here in the top right-hand corner is Hong Kong data from earlier on in their epidemic, their first wave. And on the left, the 3 clusters are from religious ceremonies and weddings and things. And on the right, the big circle is really all the other cases. And you can see most of them were dead-end events, meaning that they didn't go on for onward transmission. And although quarantine was happened in some of the cases, it wasn't actually for all, which means that it kind of seems to just sort of die out. And being asymptomatic, it's responsible for fewer secondary infections than symptomatic and pre-symptomatic cases, and that's from a recent systematic review that has found that asymptomatic secondary attack rates are very low, between 0 and 3%. And then for those that are symptomatic, their attack rates are 1 to 16%. And so that goes again with this idea that very few people are responsible for most of the events in transmission. And where these onward transmission events occur, it's associated with living with an index case or a group activity, so close contact. And these are the things that seem to drive onward transmission. So looking at children in transmission, we know that children get infected, but less so. This is Australian data, so less so than, their parents and older age groups. But what we don't know is whether it's more, less, or the same as adults. And this is because there's mitigations in place to prevent them from transmitting. So we actively ask children to stay away from grandparents. We shut down schools if there's a case, and all those other mitigation measures that are available, and very important in the community. And we also know that testing only symptomatic children, not identified children who may be silently transmitting the virus, who may be infectious. So all of these things together mean that we don't really fully understand the natural history of children and their role in transmission. Nevertheless, children do transmit. I mean, there is no doubt about that. So, there was one study, a large study from South Korea, that found that older children, so children more than 10, may transmit at a similar rate to adults, but younger children may transmit less than adults. But there's a couple of studies also that show and indicate that children may transmit to a similar degree as adults. And this is school camp outbreak data from the US and also some recent data from India. There's also data that shows that children less than 5 with mild to moderate COVID may have high viral loads, suggesting that young children can potentially be important drivers of the virus. And we know that with adults with high viral load, that that is a predictor really of severe outcomes for adults, but we don't know for children as yet what that means. However, it's unclear how long children shed live infectious virus for. So even though children might be PCR positive, it doesn't mean that the virus is actually live and that they're actually infectious. However, child to child and child to adult transmission does seem to be uncommon. Now, there was a meta-analysis yet to be published yet on household transmission clusters. And what they found was that adult index cases were far more likely to cause secondary transmission versus child index cases, and vastly so. So, 98% from adult and 2% from children. And secondary attack rates in child household contacts was also lower compared with adult household contacts. So this means that that children get infected, but it seems that they might be getting infected less, and their role in transmission may well be vastly lower. And this is another systematic review, again, not published yet, that was done looking at transmission in children. And in 3 school studies, they found that there was minimal transmission by children or teacher index cases. They found a lower seroprevalence, so antibody levels in children compared to adults. And what that means is that is your prior history to exposure and the infection. So, so that takes into account asymptomatic cases who mightn't have been tested, but looks at exposure to the infection at a population level. But they did found that the seroprevalence in adolescents was similar to adults. Although the evidence was very weak, children and young people play a lesser role in transmission at population level, so meaning spreading it all around the community as such. And that, but it's important, this factor, what children's role in transmission is really important to understand, because we may need to vaccinate children once there's a safe and effective vaccine, and as long as it prevents transmission, because we don't want to have to live like this forever. We want children to be able to see their grandparents, and we also want to not have to shut schools down. And at present, it's unclear how infectious asymptomatic children are, so we need to actually test them and find out. However, that information does not stop, children going back to school, not knowing that, because we have these mitigation measures that actually work. So looking at the data for transmission in schools, at low levels of community transmission, this is in the broader community is what I'm referring to, reopening schools has not been associated with an increase in community transmission. School infections occur as we know, but not at greater risk of infection in school than the broader community. So infections in schools seem to mirror what's happening in the broader community. And if proper and consistent measures are in place, schools aren't at greater risk of infection than other places and unlikely to drive transmission. So it's no higher risk of getting an infection at school as you are in the household or from somewhere else in the community. So this is New South Wales data. And so this is close to home and, what's happening in our country, in our environment with our household sizes, etc. So this is really important data. So in New South Wales, this is the first wave here, mostly associated with the Ruby Princess earlier in the year. During that time, not many kids went to school. And then school started going back at the end of April. And then there was a little bit of, towards July and August, a little bit of community transmission. And so in schools, the Department of Education limited parents on site, had additional cleaning measures and individual hygiene measures, and limited the interaction between ages, and also stopped indoor sports and music and singing. And so with that, they then monitored the infection rates. And so they looked in term one when, most of the schools were closed, but at the height of community transmission. And they found 27 cases. In term two, they had 6 cases. And in term three, 40 cases. And then they tested all of the, as many contacts in high school, primary school and childcare as they could get. And then they found that very low rates of onward transmission. And they found overall, if I could press 73 cases overall and very low rates of onward transmission. So about 1% of onward transmission. So how they achieved this was low community transmission, school mitigation measures and rapid response. So shutting down the schools, investigating the schools, putting people into quarantine quickly achieved those results. When we look at Finland versus Sweden, this is in June, up until June of this year, and we know that Sweden had a more of a light touch approach in terms of their mitigation measures. So Finland initially closed schools and Sweden kept them open except for children greater than 16. And primary school closure and reopening in Finland did not change infection rates in primary school children. Rates of infection in 1 to 19-year-olds were no different between the two countries. And there was no increased risk in Swedish teaching staff versus other professions. Now, this is data that came out recently from Germany, from a province there, which has a population about twice the size of Victoria. And so they had their first, wave here earlier in the year, and then they reopened at this point here when their community transmission rates were about the same as Victoria a few weeks ago. And then they reopened schools, and then over 2.5 months, there was no increase really in community transmission, and then schools were closed for their long summer break. And how they achieved that was, again, mitigation measures. So they reduced class sizes by 50%. They had lots more cleaning, improved ventilation, and they cancelled all those aerosol generating activities. Now, school outbreaks in EU and South Korea. So far, there's been no major outbreaks in the EU, but as we know, a lot of the schools have been closed, and particularly over the long school break in July and September, and they're just starting to reopen now. But we also know in the EU that community transmission is really getting up there and extremely high in many countries. In South Korea, which is sort of, one of the success story countries, so mitigation measures in school were determined by each individual school, and that was based on the number of students in the school, and also local transmission rates. And so what they found here, so on the right here, they restarted schools here and then did their analysis over this period here, and they found that child infection rates remained stable. But we also know that things change. So in South Korea, there was this cluster of cases that occurred in early August that was associated with a couple of church mass rally gatherings. And because of that, then that got into the school, and there were 200 staff and students infected. And then later on in August, the schools were closed in Seoul, the capital city of about 10 million people, except for year 12 students who were still allowed to go. In addition, they did all, they restricted all of these potential outbreak settings, which are known to cause, clusters, high density, lots of people gatherings. And so Seoul now is sort of coming down, is getting their wave sort of down again, and they do lots of testing. And then Hong Kong, 7.5 million, a little bit bigger than Victoria. Secondary schools reopened in late May, sort of up here, followed by primary school, and there were no cases in school-aged children until early July. And they closed then the schools a week early. And they did that because in their setting, they have multi-generational households. So the grandparents live with the parents and the children. And they did that to protect the grandparents from any infection that the children might have. And so on the 18th of July, there were 20 cases in school-aged kids. 15 were linked to households, and only five were part of secondary school or tutorial clusters, and there was no evidence of onward transmission. And so they've got a lot of infection control measures in place, and schools have reopened again last week. And in Hong Kong, they have a daily average of about 10 cases per day at the moment. In England, up until August, again, they analysed their data in schools and found attending preschool or primary school brings no additional risk to either staff or students. And so this was in the low period during their, during their epidemic of, in terms of community transmission. 0.01% of all preschools and primary schools had an outbreak. And so that was 70 cases in students out of more than 1 million children attending preschool or primary school. And what they also found was infections in the wider community was likely to be driving cases in schools, as children were more likely to acquire infection at home, so from the household rather than their school. And they found actually the seroprevalence of antibodies in children attending school versus those that weren't attending school to be actually very similar. But we also know that the UK, things have changed again. So there's now frighteningly more than 14,000 cases per day. And in grey here, you can see there's an increase in school. So again, it's proportionate. What happens in the community then goes on and happens in schools, which is really only common sense. But of course, we also know that outbreaks do occur. And so it's important to understand the context of how that does occur. So in Israel, an outbreak occurred in a secondary school. There was a heat wave. They had recommended masks to be used in secondary schools, but then they had come off because it was so hot. And then the air conditioning sort of came on, and we know ventilation is extremely important. They have very large classroom sizes, and there was also lots of mingling after schools and also travelling by school bus. And so in the US, there was an outbreak in young children and teenagers in a school camp. And again, this is sleeping in dorms, singing, sports, indoor dining, all these things together. So, there is no doubt that children are susceptible to infection and transmit the virus, but mitigation is extremely important. And so now I'm just going to hand over, that's my last slide for the moment, and I'm going to hand over to Kat to present the results of the analysis of the Victorian data. Thank you.
Okay, so I'll be presenting data from the analysis that we did with the Department of Health data, and there's two main aims in this analysis: to look at the transmission of COVID in early childcare and school events, and to explore the impact of the public health actions on COVID transmission in these settings. So we used the Department of Health notification data, so for all COVID-19 cases notified to DHS in Victoria, and also outbreak management data from Department of Health and Department of Education. There's a couple of definitions that are important for my presentation. So an early childcare or school event is an occasion where there was at least one staff or student who attended childcare or school while possibly infectious. And so this event would result in public health actions, including closure, contact tracing, and cleaning. And an outbreak is when there's two or more cases in a childcare or school event, with cases residing in different households. So we found that from the 25th of January, which is when the first case was notified to Department of Health, and the 31st of August 2020, there was just over 19,000 cases of COVID-19 notified in Victoria. And just 1,635 of these cases were linked to childcare and school events. During this time, there was 343 events in childcare and schools, and 2/3 of these cases, of these events, involved a single case. So only 1/3 progressed to becoming an outbreak. Of these events, 113 were in childcare, 87 were in primary school, 40 were in combined primary and secondary schools, 95 were in secondary schools, and 8 were in special schools. When we looked at childcare and school event cases compared to those in the general population, we found that the cases broadly were similar to those in the general population. So you can see that the number of cases in total in Victoria is in the black line, and those linked to childcare and school is in the purple line. And the increase occurred at roughly the same time and declined at about the same time. And this blip going down that we see here in the childcare and school events is when there were school holidays. We also see that cases linked to childcare and school events broadly reflect geographically what's happening in the rest of Victoria. So these are two maps of Melbourne local government areas. And we can see in the map on the left with the purple shading that there's darker shading in certain LGAs, and that darker shading represents more cases of COVID in that local government area. And we see that the darker shading in the left largely mirrors the darker shading in the right, which is cases that are not linked to childcare and school. So when we look at the characteristics of cases linked to childcare and school events, just over half are female. And this isn't surprising given that the workforce in childcare and school is majority female. Just under half were aged less than 19 years, and less than 1% were aged over 70 years. So this was an important finding to us because it suggests that there wasn't a significant amount of transmission to those who are most vulnerable to COVID-19. But given the restrictions that we had on visiting different households, it's perhaps not surprising. Only 8 cases who were staff or students were ever hospitalised, and all have recovered. And 91% of cases linked to childcare and school events reside in Metro Melbourne. When we look at the relationship of the case to the outbreak, we see that only 16% of cases linked to childcare and school events were in staff members, 37% were in students, and 46 were in household contacts. So these are people who live in the same house as a staff member or student, but haven't necessarily attended the site. And so if we look at this relationship to the outbreak, or to the event rather, over time, we see the pale blue are the household contacts, and we see that there's a significant proportion throughout time linked to households, whereas staff are the pale purple and darker purple are students. And so we're doing some additional work to look at who these household contacts are and how they're related to the school event. And it's looking like up to 50% of these household cases are in the household of the first case linked to the school or childcare event. And so this suggests that potentially there's some level of transmission happening in the household, including acquisition of COVID-19 by the child, and then that child has taken it, or child or staff member, sorry, has taken it then to the childcare or school. So one of the things that we really wanted to look at was does age impact transmission? And so we broke it down based on the age groupings of different school settings. So we've got the 0 to 5-year-olds, who are essentially those in childcare, 6 to 12-year-olds are those who are in primary school, 13 to 15-year-olds who are junior secondary, 16 to 18-year-olds who are senior secondary, and then adults aged 18 years and 19 years and over, who we assume are all staff. And so we see here that there's quite a small number of events. So this is the total number of events by each group. And there's not a huge number of events in those aged 13 to 15 years. If we have a look at the events, specifically those aged 0 to 5, so up the top we can see that in total there's 62 events where the first case was aged 0 to 5 years, and only 9 of these events progressed to becoming an outbreak. And if we look at that as a percentage, which is in the bottom figure, we see that this equates to just 15% of events when the first case was aged 0 to 5 went on to become an outbreak, or there was some level of transmission at the site. If we compare that to when the first case was aged 16 to 18 years, we see that there were 75 events where the first case was a senior, an older adolescent, and 30 of these events had some level of transmission and went on to becoming an outbreak. And then at the bottom, if we look at this as a percentage, this equates to about 40% of all events where the first case was an adolescent, aged 16 to 18 years, went on to become an outbreak. And we see that there's a similar proportion of events becoming outbreaks if the first case is aged 13 years and older. But again, remembering that we don't have a huge number of events where the first case is aged 13 to 15, so that data is a bit limited. We then looked again to look at this a bit further, to look at the size of the event based on the age of the first case. And we can see here, if the first case was a child aged 0 to 5, the median number of cases in the outbreak was 1. And that's not surprising given that we only had 15% of these events went on to becoming outbreaks. And we also see that if the first case was a child aged 0 to 5, the median number of close contacts was 21. And if we look then at adolescents aged 16 to 18, as the first case in the event, the median number of cases in that event was 4, so a much larger outbreak. And also there was a much higher number of contacts that I can't see. So there was 54 contacts was the median number. And we see that as we increase the age of the child or the student, it increases the number of contacts. And this stops though when we get to adults. So with adults or staff members, the median number of cases in these events was 3, but they had much fewer contacts. So just 15 close contacts if the first case was a staff member. So there is a significant public health effort involved in childcare and school events. And we found that there was almost 20,000 contacts linked to childcare and school events up to the 31st of August this year. 48 of these events involved over 100 close contacts, and secondary school events had the most close contacts with a median of 53 per event. And this is perhaps not surprising given the way that secondary school classes are made up, and you might have a number of classes with different classes with different students. So if we look at the public health actions by the size of the event, we see that the size of public health actions increase with the size of the event. So whenever a case was notified to the Department of Health in a childcare or school student or staff who attended while infectious, the site was closed, and this gave the facility time for a deep clean and the Department of Health time to do contact tracing for all close contacts. And the facility wouldn't be reopened until all contacts had been contacted. So we see if there was a single case in a staff member or a student, so we had 212 events with a single case. The average number of contacts was 26. It took 2 days on average from the first case to be notified for the school or childcare to close. And on average, these facilities were closed for 7 days to enable deep clean and contact tracing. And if we look then at the largest outbreaks or events, so those that had more than 10 cases in staff members or students, and there was just 12 of these events, so they weren't very common. But the size of the public health actions was much bigger, with an average of 359 close contacts. It took 3 days on average to close these facilities, and they were closed on average for 22 days. And given that the Department of Health would make sure they contacted every close contact when new cases would be coming through, that explains why these facilities were closed for a bit longer. So to summarise, early childcare and school events were largely driven by community cases of COVID-19, and we see this both over time and geographically. We also see that when the first case in an event was a young child, it was unlikely to progress to an outbreak. We see that when the first case was an adolescent, there were more secondary cases and there were more close contacts. And when the first case was in a staff member, there were more secondary cases, but fewer close contacts. So different dynamics depending on the age of the first case in the event. And we also see that the swift public health actions likely contributed to limiting the size of these events, with facilities rapidly closed and contacts isolated. And that is the end. I will hand back to Fiona.
Very much. Okay, so based on that and based on the international review that we did, we recommended that early childhood and schools should be prioritised for reopening and staying open. Closing schools should be a last resort, especially for early childhood and primary schools. And mitigation obviously is extremely important. So we recommend a staged mitigation approach to opening up and to gather more data and evidence through school surveillance in term 4 to inform future education and health policy. So we reviewed all the school education data over in the better performing places. Some countries may be doing more than what's actually listed there. It's just that it wasn't on their website, but these are the main things. Masks are particularly variable, but mostly, as we know in Asia is common, but not, New South Wales, masks are not required. Everywhere does enhanced hygiene and cleaning and physical distancing. And ventilation, although we know that's extremely important, that's become sort of more recently known to be important. And again, schools may be doing this, but it's just, it's not what I could find on websites. So our recommendations were based on this Harvard Healthy Buildings program. So we looked at this compared to what the Department of Education currently had listed. And in addition, we added additional measures regarding ventilation, which is so important. And we came up with some school mitigation strategies. And this is what the US does. They base it on a traffic light system on risk level. So on the left is the risk by incidence rate in the region, and basically schools or areas can dial up or dial down their mitigation strategies based on how much community transmission's happening in their local area. And so that's what we did. We came up with a traffic light sort of system. I'm not going to go through all the details of this that we proposed to the department in terms of recommending this traffic light system. So in summary, green is standard precautions, and then in yellow is masks for teachers and staff and secondary students, enhanced physical distancing, especially for the staff, and none of these potential aerosol generating events. And then in orange, just sort of 50% of classroom size for years 7 to 10. And so how that then we thought could be then synced with the Victorian Government's Road to Recovery steps. So currently, for Metro Melbourne, we're in the second step. And so we had recommended to go back in orange, which is really all of these things plus half attendance for years 7 to 10. However, as we know, the modelling, there's been an announcement of that, so the kids are going back, which is fabulous, just at the end of this month. But the important thing is that as we go forward, things can be dialed up or dialed down sort of more at a local level. And so this is a hypothetical example of Victoria where, regional, there's not many cases, Metro's got more cases, and if there was a cluster occurring, for example, this is hypothetical in Apollo Bay, then rather than shutting down the schools, the education department could dial up to the yellow, to try and prevent schools from closing, but have enhanced mitigation strategies. And this is what the US does, and sort of a color coding map is how they use and sort of manage things. And so are Victorian schools ready for term 4? Well, we have low community transmission, and yesterday was amazing. Victoria had fewer cases than New South Wales, and I don't know when the last time that was. We have school mitigation measures in place, and that's being ramped up as well. And also, as we've demonstrated, even at the height of the epidemic, that 2/3 of cases were only a single events. They were aborted, and more than 90% of cases in Victoria were less than 10 cases, and schools were shut down on average within 2 days. So, and the department's wanting to shut down if there are incidents within 1 day. And we also know that the most important thing to keep, COVID out of schools is our own individual actions. And so, all those mitigation measures that we've been asked to do are really the key things to keep our kids safe in school. And just a last slide. Last couple of slides, those enhanced mitigation strategies, I won't go through, surveillance strategies is really important to understand more the transmission in schools, and also the mental health impacts. And Margie can talk to, and Sharon can talk to that in more detail. And that will be occurring in term 4 with the aim of having additional strategies in place for term 1 of next year. And so, it's been very, obviously very rewarding and an honour really to sort of lead this work, and the impact has been immediate and enormous, and being able to get 1 million kids back to school and, this enormous relief both for the kids and their families has been truly a very rare experience for all of us. So thank you very much, and happy to answer any questions.
So thank you to all of our speakers. And now we've got an opportunity to get into the Q&A. I would just like to introduce our additional speakers today. So welcome to Dr. Catherine Snow, who's a Research Fellow at the Department of Paediatrics at the University of Melbourne. Associate Professor Margie Danchin, who's a General Paediatrician and Immunisation Paediatrician at the Royal Children's Hospital, is a Group Leader of Vaccine Uptake at MCRI and a Clinician Scientist Fellow at the University of Melbourne. And we're really delighted to welcome Leanna Buchanan as our special guest. Leanna commenced as the Principal Commissioner for Children and Young People in 2016. and also sits as a part-time commissioner on the Victorian Law Reform Commission. And thank you so much, Leanna, for joining us. So I'm going to hand over now to Sharon, who's going to facilitate and mediate the Q&A. So over to you, Sharon.
Thanks so much, Andrew. And it's just been amazing so far to hear all of that detail. But now we're going to try and do Q&A hara-kiri and see if we can make this work. But what I first want to do is I want to actually ask Leanna a question. I started this whole presentation talking about the impact on children and young people, and that one of the things we've all been very concerned about is whether we actually have eyes on kids and young people. And many of us, and I'm sure many of you in the audience, increasingly feel that we don't. But I might just hand over to Leanna just to get a view from the Commissioner's Office, what they've been finding, because I think this is really where we need to focus our energy now. So Leanna, just over to you to get your thoughts.
Thank you, Sharon. In terms of the work that we've been doing at the Commission, really as soon as we moved into restrictions at the end of March, we shifted our work and we started really quite intensively working to oversight what was changing for children, and we particularly focused on child protection, youth justice, as we're legislatively required to do, and education. Really looking at what was changing in terms of service delivery for vulnerable children and what impact was that having. And at the same time, we started a program of engaging with children and young people to ask them exactly that. How was the experience of COVID for them? So over about 6 weeks, we spoke to about 650 children and young people, 350 of them directly, and a number of others through in-depth surveys. So I'll just touch on 3 areas that we've been focused on from that work and concerned about from that work, just very quickly because I'm conscious of time. And really they're 3 areas that underscore why I am so pleased, so incredibly pleased that the health advice now supports children and young people returning to school on site. The first area that I'll touch on is mental health. Again, I could talk at length and I won't. Bottom line is, of all of the children and young people we spoke to, well over half of them described this period having a negative impact on their mental health. Some of that was mild, some of it was severe. A disproportionate or alarming number of children and young people described suicide amongst their peer groups or being concerned about friends or peers who are at risk. So that was a very, very strong theme. The second area I'll touch on is safety. Now you mentioned, Sharon, the notion that there have been less eyes on kids during this time. There is no question about that. We know that schools are a major notifier to child protection, for example. The reality is during this period, we've had an awful combination of, in all likelihood, greater risks of family violence, substance abuse, a whole raft of drivers of harm to children in the home. That's happened at exactly the same time as families have largely been stuck at home 24/7, and at the same time as children have been less visible. And at the same time, even if concerns are raised, services, including child protection, have had less capacity to respond to those services because of the reduction in face-to-face work. It's really hard to assess risk to children and respond to that risk, or to engage with families if you're doing it just by phone. So all of those issues have made this a very high risk time for children. And in terms of what children told us about that, again, I won't go through all of that, but one of the things that children and young people described was where there was conflict at home, where there was violence at home, they talked about their usual strategies not being available. So that for some, that was about going to stay with a friend for a couple of days. But for many, it was about actually school provided their only kind of safe hours in the day, and they didn't have access to that kind of respite during COVID. The third area I'll touch on is education, because of course we're talking primarily about schools. And again, I could talk at length, and you described it, I think, in your introduction, Sharon. Based on what we heard from children and young people, there is no doubt that this has been incredibly difficult for many, many children and young people, and particularly so for children with special learning needs, with disabilities, and particularly for children who are from families where they're doing it tough, for whatever reason. There's no question in my mind that to the extent we had an education gap before, it has widened. And as we seek to get children back on site, the sad reality is many children in particular cohorts will have disengaged completely or will have massive catch up to do. So for all of those reasons and many more, I'm so pleased about this research. I'm really pleased that we're seeing children and young people going back on site. Part of my effort, and I think our collective effort, is now that we're going to have to be ready to respond to the issues and disclosures that emerge when we do get children back. Thanks.
Thanks so much, Leanne. I'm so pleased that we got to hear about that. When we just so the audience knows, when we first started thinking about that, we just wanted to make sure that whilst we're talking about infection control and a sense of, as quite rightly, people are worried about what's going to be happening, I think we're always balancing, aren't we, those issues of what's safe for kids and what's not safe for kids outside of the school. And I think that balancing out, that's why it was so interesting that reading that article by Peter Singer, the ethics of that balance is, you know, really, really troubling for a lot of us. So thank you very much for that. And I also want to mention, we do have the capacity to go for a little bit longer. So we might go just a little bit longer. I know some of you might have to hop off, but since we've got this wonderful panel, I do want to make sure that we get the chance to answer some questions. So Andrew, I'm asking you, you're my noter of questions. Throw us one.
Yes, so there's a bunch about singing and music, which I'll come to in a second, but there's a question here from Peter Barnett. How do you know that the child, I think it's essentially, how do you know that the index case is the child or the adult within the family? Can you clarify that?
So I might ask Catherine for this, because she did quite a lot of work on the analysis, and this is really about how do we know about the direction of transmission. So Catherine, over to you.
Yeah, thanks, Sharon. So yeah, look, there is, it's not a perfectly exact science with this, because we are limited to looking at the date that either the person first developed symptoms or the date that they were diagnosed if they were asymptomatic, which some children are. In this analysis, we restricted it to only staff and students at the school. So if a parent developed COVID and a child developed COVID and the child went to school, then the child would be the index case, because the child was physically present at the school and the parent usually would not have been. So in that analysis, we're comparing cases among students of different ages to cases among staff. And we're not including parents and household members in that analysis. But it is a limitation, especially when in households, you might have multiple people in the same household who are all exposed to the same index case, and they might get sick on different days, but that doesn't indicate that someone within the household gave it to someone else. Actually, they've all caught it at the same place. So there's lots of complexities there in terms of, you know, figuring out exactly who gave what to who under different circumstances. And that's one of the things that we recommended further research on in Term 4, and that lots of research is going on around the world for as well, to try to tease out some of those who gave what to who questions, because they are quite complex.
Thanks, Catherine. And actually, Andrew, I might just whip onto a pivot from that. I'm not really talking unless I say pivot. I was going to ask Margie just about, because I think Catherine's brought up this very real question we have, which is trying to work out the direction of transmission is actually really complex. But one of the things we've been thinking about in terms of what the extra data that we're going to gather in Term 4 is trying to unpack that. So Margie, do you want to just talk very briefly about what that proposal is about?
Yeah, thanks, Sharon. So we're in discussion with the department at the moment about creating an enhanced surveillance response or proposal, essentially to try and determine if we can pick up more primary cases at the same time as the index case, and a lot of those may be asymptomatic, and more secondary cases at that sort of more 11 to 14 day time point. And so what that would entail is enhancing the department's current response which is detecting, which is following the close contacts of the index case and then doing testing at around that sort of day 11 time point, to actually doing baseline testing on all contacts, close contacts, and the rest of the school, as well as testing at that 2-week mark, again on the close contacts and the rest of the school. So we're proposing to look at looking for virus, so PCR probably on saliva at baseline in 2 weeks, and then also looking at potentially doing some serological testing at that 2-week mark to see if we can detect some upstream cases and previous infection around the time of the primary infection. So I think, as Peter Barnett pointed out, we don't really understand a lot about the transmission at the moment from the current data that we have. And one other important aspect that we're also trying to look at is what proportion of students potentially return to school once the school is reopened, if they were not a close contact. Sort of some of the quality of the communication from the department, or the interpretation of that communication, particularly amongst culturally and linguistically diverse families. And also testing, who is tested when they are asked to be tested. And then one other area that I'd just like to raise that we've become aware of as well is around stigma of positive cases in the school, and also of a child attending a school that has a positive case. And I think we've become aware that, there are many children who themselves were positive, who may be being bullied and are concerned about returning to school. And I think that that's something else that we need to be thinking about carefully, is managing that and having resources and support available for the child, but also for the school itself in terms of managing positive cases. So I'll send back to you.
Thanks so much, Margie. And I know there are some questions on music and singing. So I think what I'll do is I'll now just throw to Fiona. We've had a lot of questions come through about when's appropriate to do certain singing, woodwind instruments, and in fact, there's chanting and other things that also goes on in schools. I don't think we're probably going to be able to give all the down in the weeds kind of responses, but I know we've been talking quite a lot about it. So Fiona, I might just throw to you.
Thanks, Sharon. I just wanted to add one thing to Margie, just about, and Catherine, about the direction of transmission. It's quite right. We can't determine in our analysis the direction of transmission, but what we can determine is really the extent to which the event goes on and on. And so we're very confident in that data in terms of, a single event was a single event in 2/3 of the cases. So, it didn't pop up in other sort of places. So I just want to clarify that. In terms of the wind, the music and things. So it really is based on adult data. Actually, it's not actually child data, but on the transmission from choirs and from wind instruments and things that can cause large exhalation, from the lungs, which can aerosolize, the virus potentially and transmit it further. So that comes with physical activity and breathing hard, with wind instruments, and potentially with singing and chanting, as Sharon sort of mentioned. But the only data is from adults, it's not from children. So this certainly doesn't mean that, these things can all go online, and it doesn't mean that guitar and violin and those sorts of things stop, as long as the 4 square meter rule. You can have an orchestra, but the poor old wind instruments might need to be online for the interim. But certainly online is no problem at all, and not having wind instruments. It's really mainly that, and it's more so in teenagers, because their lung capacity is sort of similar to adults, and so they're able to exhale similarly to the same similar extent to adults.
Thanks so much, Fiona. And we do realise that there are lots of nuanced responses here that are probably well beyond what we can really talk about. And you can imagine how challenging that is for schools to try and work through all those nuances, keep kids safe, make sure kids are still doing some music, that, these are just not some zero decisions. Andrew, back to you. What's some of the other themes that are coming through?
Yeah, so there's a theme around children with complex needs, with disability, complex medical conditions or immunodeficiency, from Karen Dimmick, an anonymous attendee. So just, I guess, questions around additional precautions and guidelines for children with special needs.
So I think, Fiona, I might start with you again, just in terms of what our learnings are internationally. And I think this is obviously really important. And the reason the special needs question has come up, because a lot of these kids, particularly in special schools, will actually need the laying on of hands. So it's not that you can be a teacher just out the front and the kids away from you, but you're actually going to have to look after them. So either Fiona or Margie might pop up in some of the work that we've been doing in special schools and what we're sort of seeing there, and some of the recommendations for special schools.
Yes, thanks, Sharon. I can sort of start. Certainly in the data from Victoria in the special schools. So these are, children with complex needs, whether it's physical or intellectual issues. And we found that they were at no higher risk than other schools, for example. But then there's these additional children with immunological disorders, or their families may have immunological disorders. And so I might hand that one to Margie, really, because really it's probably a direct, in terms of seeing, what that condition is, and obviously would need direct, individual attention, I would think.
Yeah, thanks, Fiona. And I think Mike South highlighted this really nicely in the chat. When this comes up, I think we really need to look closely at balancing risks. And I think for a lot of children who attend special schools, again, this is so important for them and for their families in terms of managing some of these children and for them to be back in that supported environment. So I think given that there isn't necessarily a higher risk for these children in terms of getting COVID, I personally think we should be prioritising those children being back. And in fact, I'm aware that most of the special schools, or many of the special schools, were still having a lot of children attending all the way through COVID here in Victoria. Certainly a number of my patients were still going, which I think is fantastic. And in terms of the, having an immunodeficiency, I think that needs to be assessed on a case-by-case basis. But I think given that COVID is generally mild in children, I would still err on the side of a lot of those children being able to attend safely with mitigation measures in the classrooms and with the teachers and things. But I think it would have to be assessed one-on-one. But yeah, real balance of risk, I think.
Yeah, I think you're both absolutely right. But I think it is reassuring that even, you're right, Margie, there was a lot of kids still going to school, special schools particularly, because there was a real awareness, I might add. And this happened during the first stage of the lockdown. Special schools were actually not really available. And there was a recognition that these kids really, really had to be at school. And so the fact that even during the heights of the pandemic that we didn't get these massive outbreaks in special schools, I think should be very reassuring. Andrew, I think we've probably we don't really have time for one more, but we'll do one more anyway, because it's Friday afternoon. What the heck?
Sure, and just thanks everybody for your great questions in the Q&A. It's very thoughtful and really helpful. But maybe one is a good one to finish with, which is sort of smushing together a couple of different comments, but it's around parents and families being aware of mitigation strategies and approaches and communication of that to families and to children.
I'm gonna ask two people to respond to that. I'll ask Margie because communication is her specialty, but I'm actually going to ask Leanna as well, because I think that's actually the role of the Commission to actually be communicating with children and young people. And so, Leanna, I might just start with you to get your views on this.
I might start by saying it is absolutely part of our role, but actually I think any services and any departments that have children as a primary recipient of those services also have a core duty to communicate to children. And some of what we heard from children and young people in our engagement was that whether it was information about COVID and health risk and how to stop the spread of the infection, or if it was information about what was changing to their schooling and why, or if it was kids in out-of-home care wanting to understand why suddenly they weren't hearing from their worker for a while, children and young people almost unanimously said, we need more information. We're not getting tailored, accessible information about what's happening to us. So I think the point is very, very well made. As students go back to school, the communication to parents, the communication within the schools, and the communication to students themselves is going to be really important. So everybody's on the same page. That might mean the messaging has to be a little bit different, but everybody should be on the same page about what's needed and what's needed to keep people safe. So I hope that is going to be a focus, and that's going to have to happen at department level, at school level, at the very kind of local level as well. But communicating to students in there is oddly a part that can be lost. So my message is we can't afford to do that.
I think you're so right, Nana, that and we've heard this time and time again now that kids are not feeling like they're getting messages that make sense for them. And we're hearing it through some of the feedback, through some of the adolescent and young people work, even coming through the Commonwealth. So I think that is a group we're missing out on. And Margie, this is your area of expertise around health communication, and just also this disturbing finding around, and I'm sure, Leanna, this makes sense to you, around this idea of stigma, what's happening for kids. You know, you can even imagine it for yourself as an adult, can't you? Like, no one wants to read a person who's got it, you know, and you just kind of, you know, so imagine what that's like for the kid, and not being able to actually explain that in a way that makes sense. So Margie, I might hand over to you.
Yeah, thanks, Sharon. I think it's really crucial that whatever communication goes out to students is really developmentally appropriate, obviously. So it's going to differ between primary and secondary. But I think it's really important. There's a lot of sort of behavioural fatigue out there. People, especially in Victoria, people are struggling. And I think for students, they need to understand why we're asking them to, for example, wear masks at school for secondary school students, so that it makes sense to them, so they can be at school, because they're all desperate to be back at school. So the mitigation measures need to be clear, and the rationale behind them as to why they're being recommended clear. And then I think really importantly, balanced with positive messaging, so that they are seeing their friends, and that they can still engage in physical activity and sport as long as it's socially distant and outside, and not necessarily arranged school sport, but I mean staying physically active. So that there has to be this balance of positive messaging for them. And then really importantly, I think we need to also have the capacity as part of all this communication to be able to detect when kids are in trouble. So to be able to detect some of these mental health issues around anxiety and depression in kids by teachers, and communicate with parents, and then, you know, link them with resources. Because I think we need to be able to respond as well as, you know, effectively communicate with them. So I'll leave it there. Thanks, Sharon.
Thanks so much, Margie. And I might use that as a plug to just say that one of the things we're looking at in our surveillance work is actually looking at the mental health of kids, hopefully both in term 4 and in term 1, so that we can give some real data, both back to schools, but also back to health policymakers and education policymakers, knowing what are we actually going to do, what's the burden coming our way, and how do we actually respond in a really sensible and, you know, evidence-based way. Because it's easy in some ways to go, oh my goodness, let's just throw things at these kids. It's much harder to go, what do we do systematically, and how do we evaluate that? So thank you very much to all of the panel. They've been fantastic answers. There are a heap more questions, and we'll try and capture those and try and work out a way of maybe communicating through the MCRI website so that some of this information becomes available. But Andrew, back to you.
Thank you, Sharon. Thanks for all of the participants and the speakers today. It's been really great to be able to share this information, and thank you for the attendees. I think we had over 220 attendees today, which is terrific. And a particular thanks to you, Leanna, for joining us as a special guest. And I think I might close with a comment from Alyssa, aged 12, and Fraser, aged 8 in the chat. Thanks for helping us get back to school. And it really is just so wonderful, I know as a parent myself, to have our kids getting back to school next week. So thank you again. The next webinar is on Friday, the 6th of November at 1:30. It will be on vaccine preparedness. And Belle Overmars, whose email was in the chat, you can contact her to register for that. We'll be sending out some more information. But thanks again to everybody today, and take care.